Hello everybody, welcome back to the Stat Dose podcast. We're here today doing a stat medical topic on anaphylaxis. So, I suppose we should probably start with a definition.
Yeah.
Looking around the room, blank faces.
That's right, so the eyes have rested on me. So we can define anaphylaxis as a severe, life-threatening, generalised hypersensitivity reaction of acute onset, characterised by life-threatening airway, breathing, circulation problems, usually associated with skin or mucosal changes.
And yeah, essentially that's it in a nutshell, isn't it? I mean, I was quite surprised when we were going through doing some the notes for this. Around 20 deaths a year in the UK, which I thought was quite a small number. But then I suppose it's not a particularly common disease.
No.
So I suppose it's time for a bit of basic science, everybody's favourite. So in terms of the pathophysiology of anaphylaxis, type 1 hypersensitivity reaction, I think we I remember those from med school, type 1 to 4.
Just about.
Yeah. Essentially I remember that there are 4 and 1 is bad. I think 4 is delayed. That sort of bit really. 2 and 3 exist. IGs, something or other involved in all of them. This is a room of fully qualified clinicians, by the way.
I'm keeping quiet.
I think it actually goes to type 5 now.
Does it?
Yeah.
Oh, don't. There's always a show off. What's type 5?
MRCP, don't remember.
Excellent. So with the type 1, with the pathophysiology of anaphylaxis, it's the antigen binding with sort of the causative, the antibody binding with the causative antigen, causing essentially mast cell activation, which leads to lots of things. So release of histamine is the key sort of pathophysiological factor behind it, but other things are released, cytokines, leukotrienes, tumor necrosis factor he reads off his notes. And essentially these lead to the clinical effects that we see as anaphylaxis. So you get bronchospasm, which causes wheeze, shortness of breath. The histamine certainly causes vasodilation and decreased vascular tone, which can cause the hypotension, and then you get increased capillary permeability, so that's where you get the rash from, and that's where you're also contributing to the hypotension. The other key thing to note is the biphasic reactions, and so they occur in about 20% of patients. So causative agents, guys, what have you seen in practice?
So the one that always crops up, that you see a lot on a lot of patients' charts, is penicillin.
Oh.
Probably one of the most common causes of anaphylaxis, I would argue. Then other things, I'll reel off a few. So aspirin, NSAIDs, ACE inhibitors as well. Food such as peanuts, eggs and seafood. And then you've got your insects, so bee and wasp stings. Also of note, there is hereditary C1 esterase inhibitor deficiency, which is...
Hugh looks like he knows about that and wants to talk at great detail about that.
Natural silence.
I've seen it once.
I've not seen C1 esterase deficiency.
No, it's rare. It's normally a genetic thing, but it can come into other conditions. But the key with management, it doesn't respond to your routine anaphylaxis treatment. You've got to give them a special thing. Is it? Is that what it's called?
Berinert, yeah. Ooh. That's the brand. It's only because I've seen a case of ACE related angioedema once. Okay. I gave them a lot of antihistamines, which didn't work. No. Yeah. And then resorted to Berinert.
Yeah.
And it fixed.
FFP works quite well as well.
Yeah, that's the other one.
So is that the same as idiopathic anaphylaxis?
No. So idiopathic anaphylaxis, I think it's like the third most common cause. It's just when we don't find a precursor. But it's the same immune-related type 1 hypersensitivity reaction. Whereas the C1 esterase thing is a non-immune thing, a non-allergy
through a
related
different pathway.
Yeah.
It's bradykinin, isn't it?
Yeah.
Building up.
So moving on to assessment then, I guess the primary way you'll assess a patient who's having an anaphylactic reaction is through the A to E. If we've got an anaphylactic patient, airway problems can occur. They can get stridor, you can get noisy breathing, you can get a hoarse voice. You can also sometimes see they've got lip and tongue swelling, and that's due to the angioedema, and they might have some nasal congestion.
Certainly in kids, that's why. That's a Laura perk up there, as I said.
Children! I know about that.
We should explain that Laura is currently working in paediatrics.
Yeah.
Not just a weird.
Not just weird.
So naturally moving on then to B and breathing. Yeah. So breathing problems, you can note that they're usually tachypneic. They'll have bronchospasm, which will lead to wheeze as the primary sign. Mm-hmm. You'll notice they've got increased mucus secretions, and it'll lead to exhaustion, confusion, cyanosis, and eventually respiratory arrest.
Uh-oh.
So it's 2 words you don't really want to see next to each other.
No.
onto circulation. So problems that you get from a circulatory point of view is they become tachycardic and hypertensive, and that's essentially because of what we talked about earlier with the vasodilation and the increased vascular permeability leading to a shock scenario. They can also get arrhythmias, myocardial ischemia and cardiac arrest. Onto D. So we'll split it up, start off with neurological problems that you can notice. So we've discussed already that they can be confused. You can also be agitated, or you might know that they've got a low GCS. You can see from a skin and mucosal point of view, there can be urticaria and erythematous. And you might notice they've got some linear excoriations because they're so pruritic. And that is about the most intelligent words I've used in one sentence.
I struggled to follow that for a minute.
I don't know what linear was, sorry.
Excoriations. Oh.
So that's a scratching.
Oh yeah, scratching to scratching to a layperson, I guess. Other things that you might notice, so from a GI perspective, they can have stomach cramps, nausea, vomiting and diarrhoea. That's particularly the case if they've ingested what they're allergic to.
So, like if they've eaten a peanut sandwich or something. Peanut butter sandwich.
As long as they're allergic to peanuts.
Not a peanut sandwich. No, I don't know who's out there making a peanut sandwich. Yeah, peanut butter sandwich. Yeah.
It's like a really dry sandwich.
Yes, but it's going to be horrible, isn't it? You've got to have some butter with that peanut sandwich, haven't you?
So I like a dry salami.
Do you?
Yeah. Like a chip buddy.
Yeah, but you put butter in that chip.
No, so I don't.
You don't put
I've learned a lot about Hugh today.
Bread.
He likes mauve and a dry.
And a dry chip buddy.
Yeah. Yeah, so in our sound test we do we just go through, we say like our favourite colour and a fun fact. And there are some odd favourite colours and some very interesting fun facts about Laura, particularly being some sort of ninja person.
Black belt in Taekwondo.
Yeah, it's pretty scary.
I used to do boxing.
And Hugh's favourite colour is mauve.
Likes mauve. And he's sat in a mauve-ish shirt, which apparently brings out his eyes. So
you guys can't see me right now, but if you could, you'd totally agree.
It's one of the limitations of podcast education. Anyway, we do digress. What else do we need to go through? So we've gone through our A to E, haven't we?
Essentially, yeah. I think so.
Yeah.
And I think the other key feature, which is sort of feeling of impending doom. I don't know from your guys' perspective, but every time I've seen a patient who says, I feel like I'm going to die, they've either died or they've been really unwell.
They've been right about it.
Yeah. So I think I always believe a patient.
Don't dismiss it.
No.
Carrying on with D, really, and E, actually. So, obviously, you can see the skin and mucosal changes, like the urticaria and the angioedema, but those isolated on their own isn't actually diagnostic of an anaphylactic reaction. You're likely to see some other either airway or breathing problems in combination with that. It's also important to note that although it's hammered into us that these skin and mucosal changes will be present in anaphylaxis, not always the case. So in about 20% of reactions, they can be really quite subtle, and it might not be the first thing that you actually notice in an anaphylaxis reaction. It might be that you notice a change in blood pressure or a circulation problem first.
I was surprised to see about 20% you don't get the skin changes, which does surprise me. I think it's just from my experience of seeing these patients that rash is prominent and one of the cardinal features really. But yeah, so up to 20% of patients won't have that response at all.
That's particularly worrying if it's the first presentation as well.
Is it?
Yeah. So because they don't know what's caused it, so they don't know that they're having an allergic reaction.
Yeah.
And they'll feel funny, but there won't be the signs.
So you'll be treating physiology, of which the probable cardinal feature will probably be circulatory collapse. So you'll be pumping them full of fluids, but not really treating the underlying cause because you won't know unless they start to get some airway swelling or sort of bronchospasm. Then you might start putting it together in your head. But again, just highlights the importance of the A to E.
Just for a few key features of anaphylaxis to help you in diagnosing it. So anaphylaxis is the most likely diagnosis when all three of these criteria are met. So number one, it's an acute onset of the illness and has pretty sudden progression. Number two, you'll usually notice skin and or mucosal changes, such as we mentioned, urticaria, angioedema, or flushing. And number three, there's usually life-threatening airway or breathing or circulation problems, or all of the above.